Hello, everyone. This is Paul Marquis from OEP351. This is episode 351 of the podcast. Today, we're going to be talking about anterior cervical discectomy and fusion with Dr. Nicolas Arredondo. This is going to be part one of a two-part series. We're going to be talking about who the perfect candidate is for an ACDF. We'll talk about the purpose of an ACDF, discuss a surgical procedure of the anterior cervical discectomy and fusion, and so much more. But before we get started, I just want to mention our sponsor, Rangemaster. Now, if you've ever had a patient who has complained about neck pain when using a sling, and that strap is just causing a lot of discomfort on the neck, you'll see that they'll take that sling off prematurely. And oftentimes we don't want them to do that. Okay. So here's how you bring immediate comfort and happiness to your shoulder sling wearing patient. It's called the Sling Thing Adapter. This is a patent pending product that is affordable and easy to use. And again, comfort is key. It's very easy to put on. It takes me about 20 to 30 seconds to put it on. It attaches to the contralateral humerus. You pull the strap through, it pulls that sling strap away from the neck, and instant comfort. All right. So for a limited time only, if you are a PT, PTA, OT, OTA, or any orthopedic medical provider, email jim@myrangemaster.com and mention OrthoEvalPal in the subject line. Rangemaster will give you a free Sling Thing adapter sample to try with your patients. And to see their full range of products, go to myrangemaster.com. I'll also have a link in the show notes for you to click on if you want to get there a little bit easier. All right. Back to our show. Today, I have with me Dr. Nicolas Arredondo. Dr. Arredondo is a board-certified neurosurgeon with a particular interest and expertise in traumatic, metastatic, and degenerative spine pathology, and has received specialized training in complex spine and minimally invasive surgical techniques. After graduating from Stanford University with a BS in biological sciences, Dr. Arredondo earned his medical degree at the University of Texas in San Antonio. He completed a 7-year residency in neurological surgery at the University of South Florida in Tampa, where he pursued a fellowship in neuro-oncology at the Moffitt Cancer Center. Prior to practicing at Mercy Hospital, Dr. Arredondo was a general neurological surgeon at the Neurologic Institute of Savannah and Center for Spine in Savannah, Georgia, having previously served as director of the multi-specialty Providence St. Mary's Neuroscience Institute in Washington. Woo! Dr. Arredondo, welcome to the show.
Hey, Paul. Thanks for having me. It's good to be back here.
You know, we've been working together for how many years have you been at Mercy Spine?
It's going on 8 years now.
8 years. So we've been working together for 8 years now, seeing a lot of mutual patients, everything from lumbar radiculopathy, cervical spine radiculopathy, cervical myeloradiculopathy. We've seen a lot. We've communicated about a lot. I think the relationship that we've had with your group has been spectacular, and it's just made the outcomes for patients just ideal.
Yeah, and I gotta give you credit, Paul, because a large part of that comes from you and your team, and I think that a lot of it has to do with solving the puzzle. Because while there are patients who, as you know, are real simple, straightforward, we've also had some real head scratchers, and I can recall a few that we went back and forth, tried a few different things before we ultimately came on the right answer and went down a successful path. So I really, my hat's off to you. I appreciate all your help. It's a great collaboration.
Well, I thank you for being there for us, for being there for our patients, and for taking time out of your very busy schedule to be with us today. I know how difficult that can be, and there's always paperwork to be done and other things that are super important. So, we have so much to talk about today. Yeah, we have so much to talk about today. Oh, and the other thing too is that if you are listening to this just on audio, Spotify, or it might be Stitcher or Apple Podcasts or whatever, we do now have these posted up on YouTube. So you can watch this podcast if you would like. But we have so much to talk about today, and our focus in this first part is going to be cervical spine surgery, specifically ACDF, or anterior cervical discectomy and fusion. And in our next episode, we're going to talk about the post-operative management and treatment. Like, it's crazy that there are protocols on top of protocols for everything else out there. Like, there are several different protocols for different types of ACL reconstructions or ankle reconstruction, or you name it. There's a protocol for everything, but there aren't a lot of protocols for post-op spine fusion or surgeries at all. So we'll talk about in the next episode, how do we manage some of these post-op patients after ACDF, and we'll even give you some tips and clues on how to be cautious and how to work around certain things today as we go through this. But Dr. Arredondo, what does ACDF stand for? And warning, we might be talking about some disturbing content today. So if some of you have weak stomachs, then, just block an ear or something like that. But fill us in on what the ACDF stands for. When did you folks start doing this procedure? And why was there a shift from posterior to anterior kind of gradually over time?
Yeah. So thanks, Paul. I think this is an evolution of a procedure that was really developed and perfected in the early '50s, and by the mid '50s, well published, and since that time has served as actually one of the most successful surgeries on the spine that we have in our toolkit. The the issue of what it is, it's an anterior, meaning from the front, cervical, of course, that's the region of the spine. And then you'll hear people describe it either as a decompression, which could be the D, or a discectomy. And typically discectomy is the more technically correct term, and then a fusion. And in the even as not too far back as the 1970s, the technique really was very basic, and people would go in and literally just remove the entirety of the disc, bone spurs, and that sort of thing, and then call it good and close up. At which point the vertebral space would collapse, the two vertebrae would end up fusing to each other, and a kyphotic deformity in the neck would be created. And yet this was pretty well tolerated, and even in some third world countries, you might still see some surgeons doing that simply because it avoids the cost and the need for a lot of the other implants, and they may not have the same access to good allograft donor bone implants and that sort of thing. But I really think it's really gotten standardized now around the world. Most people are doing pretty much the same sort of thing. Going in, from the front as opposed to from the back. The back was the original neck surgery. People were doing posterior decompressions, and the original fusion in the neck was a wiring. They would literally run metal wire around all of the different spinous processes. In fact, there were, I can't remember, dozens of different wiring techniques that were patented. Each one with the name of the surgeon or guy that came up with it, or girl in some cases. But in any event, I think that the transition has been towards the front because of the risk profile, because of the complication profile, because of patient tolerance and results. And so I think it is a really useful procedure for a lot of different pathologies in the neck, and typically can be well tolerated enough to be done as an outpatient. Now, not every time and not at every case, but that's certainly one of the more common things we see as an outpatient here.
Yeah, it's absolutely incredible. Like when I first started practicing, which was over 32 years ago, everything was done posteriorly. I did very, very rarely ever saw an anterior, and patients would come in with this tremendous amount of neck pain, but it wasn't related to the spinal pain that they were having. It was related to all the surrounding soft tissues that you had to do surgery to get through. And it was really tight, tough tissue. There was a lot of postural contribution to this too. And people were very, very sore. Then people started having this ACDF procedure, and I thought this is going to kill people. But they would come in, and I kid you not, this has happened on a number of occasions. I've seen hundreds of people who have had ACDFs, and they have it done like today, and tomorrow afternoon they come to the clinic to give me a hug and thank me for sending them to have that done. It's like the next day they feel immediately better, and they've got this gash on the front of their neck, and it's just so life-changing for so many people. So with that being said, I'm wondering if you can take us through from top to bottom, tip to tail, what you do in surgery for a simple one-level ACDF. Patient comes into the operating room. Take us from there.
Yeah, you bet. And just to be precise, we typically call it an incision rather than a gash, but and it doesn't sound quite as bad. But
Right.
anyway, and for your listeners and viewers that have access to YouTube, there are uh, literally hundreds, if not thousands, of surgeons who've uploaded a variety of videos of the actual procedure. So if they really want to see the, kind of the blood and guts of it, there it is. But in simple terms, this is a technique that actually relies on the favorability of the anterior neck as a good place to enter the body and operate. And you think of the neck, you think, oh gosh, the esophagus, the trachea, the carotids, the jugular. There's recurrent laryngeal artery, all these big structures that you think about. But in the end, fortunately, they actually have this very favorable tendency to be able to be separated really easily. And there's a very nice trajectory. There's actually a couple different described approaches, but a trajectory that's just medial to the carotid sheath allows us to get into that space in front of the vertebra. And that's a very minimal blood loss, if any. And it's not typically particularly painful. There's not a lot of pain sensors there. The biggest complaint that we get with going in from the front and kind of separating all the tissues, we then have to lean on the esophagus a little bit to get it off of the front of the spine, because that's the structure immediately in front of the spine. And by doing that, we create inflammation, and that results in the potential for a little bit of dysphagia or swallowing discomfort. And that can be a temporary thing that might last anywhere from a few hours to a week or so, and that's the most common. But in rare cases, we'll see it last longer. There are reports of it being permanent. People who smoke are at higher risk for that sort of thing. People with anxiety disorder, similarly. People who have pre-existing swallowing troubles. And that's really the biggest bugaboo of this procedure. And if you look at the studies that characterize postoperative complications of neck surgeries on the spine, you'll see that the anterior approach is described as having a high rate of complication, because this swallowing dysfunction is considered a postoperative complication. But actually, for the vast majority of patients, it's so well tolerated and so transient that it's really not that bad of an issue. And in comparison to the elevated risk of permanent new neurologic injury or the severe pain in the neck that you were describing in the posterior approach, we think it's a reasonable trade-off. And I think the vast majority of surgeons around the country typically tend to agree. But in
Yeah,
any
we've
event,
we've seen that. We've seen it in a few patients, and very, very few patients, and they always say, you know what, that it's still way better than the pain that I was having before. And
yeah,
and it generally gets better over time.
that's exactly right. And that generally is over 90% of patients. The frustrating thing is that it can take up to a couple of years. Now, going in from the front, like I said, allows us, and this is an incision that's about 1.25 inches, 1.5 inches, and typically a transverse incision. But it all depends on exactly what's happening, because like all surgeries, there's big and small, and a big surgery that might involve 3 or 4 or potentially even 5 levels. That's a huge event, and that's the kind of thing that we wouldn't send somebody home the same day. That's the kind of thing we would probably be really seriously, having to deal with some major spinal reconstruction. And so that's a whole separate event. The vast majority of patients who go through anterior cervical discectomy fusion are having 1 or 2 levels. Even up to 3 levels is typically pretty well tolerated and has a fairly good success rate. But as you get more levels involved, it is a bigger event. It is a longer surgery. You will get more pain. You will get longer, slower recovery, and you get more rigidity in the neck. And that's because what we're doing is taking away motion. But yeah, getting to the front of the spine allows us then to treat the pathology that's affecting the spinal cord and the nerves from the front. And that's a very effective way to do it. So we can get into the disc space, and we do it one at a time. And that's a fairly straightforward maneuver. And once you're in that space, you can then fairly effectively remove whatever's left of the disc and the cartilage. And then that allows access to that posterior area where the foramen are, where the uncovertebral joints go into the foramen, and where the osteophytes typically that might be causing some of the irritation live. And getting those out is generally pretty straightforward. And surgeon preference, different people are comfortable with different things. Whether it's a rongeur or a drill or curette or, whatever their tool of choice is. And these are, so well standardized and so kind of straightforward that although there is risk, it's typically very low risk. We always worry about things like durotomies and opening up the spinal canal and letting cerebrospinal fluid out. But fortunately for the anterior approach, that is an exceptionally rare event, and so I think that kind of safety that we get with that approach is nice. Now there are things that you can certainly get far enough into, like for example the vertebral artery, and that's a catastrophe. You can be into the esophagus, and that's a catastrophe. And you can do things like stretch or injure the nerve that goes to the voice box, the recurrent laryngeal nerve. There's one on either side, and so if you weaken one of the chords, then that's going to make it really hard for them to generate a real strong vocal response, and so they'll come in with a real soft voice, and that's a problem. And that's similar to the swallowing dysfunction, is rare, but typically recovers well. It just, unfortunately, like the swallowing, can take up to a couple of years. But so we take these risks of that sort of complication, and in turn, we're able to then address the anatomy typically from the front, where the vast majority of the pathology typically lives, as well as then have the opportunity to create fusion in the largest bony part of the spine, which is the vertebral body. And there's a whole slew of different technologies that people have come up with to generate fusion, but they all fundamentally have the same concepts. And that is that, you want to generate some rigidity there. You want to have a big surface area, and whether it's metal or plastic, and there's a whole variety of different plastics, or even donor bone, which is, kind of the old traditional tried and true. And then the most definitive and our gold standard remains using the patient's own bone. And that can be harvested in a number of different ways, typically from the iliac crest, but can also be taken from the sternum, although that's kind of a painful place to get it.
Yeah.
That's really the gold standard. And so, for example, if somebody who came in that had a history of smoking and they just couldn't quit, if they're going to be smoking, but that they still need to have this surgery, we would probably use their own bone, and I'll make a separate incision down on the hip and harvest the bone that way. Okay.
Yeah. Yeah.
The,
Now,
the
let me
proce-
ask you this. So
okay.
if somebody comes in and they have, this loss of disc space, we hear about this a lot, degenerative disc disease, basically it's dried up, it's really thin, so there's not a lot of space between the vertebrae. How do you get those separated in order to get in there to take the rest of that disc material out of there?
Yeah, and that's a great question. So there's a lot of different methods of doing that. And remember, this is a technique that's been around for 80 years, and people have tried a lot of different things. And there are some excellent practitioners who use techniques that are literally 80 years old. And then there's some brand new technology that, other folks like. And in the end, how you do it matters. And so you can do it safely, I think, in a wide variety of ways. Simple, old school, traditional ways, for example, a lot of times people would put traction on, so they might put little straps under the head or under the chin and then attach that to a weight, and that just stretches things. Others might put a bail on, and that might even have a pair of pins that would go into the skull, and that lets you really put some weight on. And that's actually a really effective way to do it. Sometimes when you're doing that, people will actually tape the shoulders, or they might have these pads that sort of push down on the shoulders, and that sort of helps accentuate some of that stretch as well. Also helps get some of the shoulders out of the X-ray field. The catch is that, unfortunately, a lot of the patients that we see that have these neck issues also have shoulder issues. And
Yes.
so you kind of run the risk that you might make their neck improve, but actually injure their shoulder. So all of this has to, tread very lightly. It's not something that you just kind of go to town and pull as hard as you can and try to get as much exposure.
Right.
But then, using kind of newer techniques, one would be going in and actually placing pins in the bone. And then we have little distractors that can actually sort of stretch those disc spaces apart. And even just, facilitating that, once you clean out all the disc and ligament that's in there, that makes it a lot easier. But, there's even, you can kind of wedge things open with separate tools, and they've got a variety of different things that we can do to do that with. Um, all of which is, the idea of control. You do it safely, you do it slowly, methodically, very intentionally, not nothing, too haphazard. And I'm describing, the traditional open, we would call it anterior cervical discectomy fusion. There are folks out there doing what they would describe as a minimally invasive anterior cervical discectomy fusion. And those are actually a whole different class of procedure. They have similar goals, but very different techniques. I don't have a lot of personal experience with them. I'm pretty amazed that there are people brave enough to do some of what they describe. But I haven't seen it catch on widely. Maybe that's the future. I don't know.
Right.
But I do hope that we continue to evolve and make this procedure better. But it's already, it seems to work pretty well for the vast majority of folks.
Right. Yeah. It
So.
doesn't seem to take very long.
Yeah, no, typically each level might take anywhere from, 45 minutes to an hour and a half, depending on the specifics of the patient anatomy and the patient's pathology.
Right.
So you could potentially do a 3-level surgery in under 2 hours. Um, and then they spend a couple hours in the recovery room, and then they, get to go home typically the same day.
Right.
But yeah, each patient's unique and each patient's different. And, I think speaking to your issue of the absence of standard protocols for treating these patients postoperatively, there is a variety, and it is hard probably to come up with a one size fits all solution to how to approach these patients on a rehab basis. Um, and when we look at, say, the difference between doing a single level, let's say C3, C4, versus a single level at C6, C7, they might have a different sort of experience. And that's a radically different thing than somebody who has a, C3 to C7 4-level fusion. Those
Right.
are, it's a huge spectrum of difference of what those patients go through.
Yes.
But I would echo that, the description. I remember one of my good friends who was ended up being a patient of mine, as it turns out, was also the husband of my realtor at one point. Super, super nice guy. And, when I first met him, I noticed right away that he was myelopathic, just by looking at him. And he told me about he'd seen some orthopedic doctor about his back, and they wanted to operate on his back. And I said, well, what about your neck? Anyway, we ended up having to do a 3-level surgery on his neck, and he did great. Thank God. But he always said, man, I never even noticed that neck surgery.
Yep.
Just, it was that straightforward for him.
Yep.
So that's not that uncommon.
So when you so now you have the vertebrae separated. You need to keep them separated. How do you do that? So you take you take bone or instrumentation to basically keep space between each vertebrae, and how do you hold everything in place? Does that just sit in there? Do you have to glue it in place? How does that work?
Yeah, so the forces of the body are working with us to make it so that things typically stay in there fairly securely. So once we separate the two bones and get into that space, that allows us to work in a little bit more comfort to be able to move things around. But once we get the area decompressed, once we're satisfied that everything's copacetic from the perspective of nerve compression or irritation, then we can put in whatever device we're using to create the fusion. Now, let's, for example, use donor bone, which might be what we call a structural allograft, and that's one of the most common things that's used. And so that's like a little chunk of bone. It's milled. It's very precisely made, so we can order them in specific increments, and they come in 4 millimeters, 5 millimeters, up to I think 14 or 15 millimeters. And then you just place it in there, and the idea is you don't want to over distract it. You don't want to put too much stress and tension on the neck, but you want to put enough. And what that does is, by separating those bones, you actually open the nerve foramina, and that's a big part of the decompression. The other thing is it also helps with alignment. So if you have, say, for example, a little bit of spondylolisthesis where one of the bones is a little bit misaligned, if you separate them, then typically with a little bit of ligamentaxis, which is that the ligaments getting stretched, that sort of pulls the bone back into a little bit better alignment. So by putting a little bit of tension on it, but not too much, then we can put the bone in there, and usually, yeah, the body will just kind of hold it. Now, and again, up until the late 1980s, that was kind of the technique. That was what was done, and it was very successful. Um, but in the 1980s, spinal instrumentation started to become more widely used, and people developed these little plates that we put on the front. And these are little 2 to 3, and I think there's even a few of them that might be as thick as 4 millimeters thick. So little thin plates of titanium alloy. and then a pair of screws into each of the bones. And it turns out that what that does is that takes your fusion rate from 60 to 70% and gets it all the way up to like 98%, and that's pretty good. So that's pretty much the standard nowadays. When people have a fusion, they're going to have some kind of instrumentation, usually a plate from the front, in order to make it really rigid in order to get a successful fusion. And
Yeah.
one of the things that's happened along the ways with that is that the need for an external collar, a rigid cervical collar out afterwards, has really gone down. Um, there are still surgeons that use it, and I think it's fine to use it. There's not anything too terrible about it. But I think that there's pretty convincing data that shows us that the rate of fusion doesn't significantly change with the use of those collars. But what does change actually is if you follow the patients far enough out, the ones who wear it for a very long time do describe more neck pain. And that probably is a result of the rigidity and loss of motion that you have from an immobilized joint, which, as you know, if you immobilize the joint long enough, it, kind of locks up.
Yeah,
So,
and I totally agree with that. I actually this is interesting that patients who have the ACDF, oftentimes, especially if they've had neck problems for a long time, and finally the straw that broke the camel's back is what brought them to you. You do the ACDF, and about a month to 2 months later, they have better range of motion than they did before surgery. Now it sounds like that can't happen because you're fusing them, but now they have so much less pain, less spasm, that they actually have better mobility. The surrounding joints are functioning well, and they actually move better.
yeah.
And so everybody says, "Oh, am I gonna? How much motion am I gonna lose?" If it's a one level ACDF, I don't find that they lose much motion at all. To be honest with you.
Yeah, I agree. And I think there's some studies that bear that out, and that's exactly right. And it really has to do with the timeline. So if you look at somebody that's a week out from a surgery, well, yeah, you're going to really have a lot of restricted motion. But once you get, 6 months out or more, then typically the range of motion is pretty well preserved. And unless I'm talking to a, contortionist from the Blue Man Group or something like that, it's not usually a big deal. But
Yeah.
yeah, it
So
is speaking of loss of motion.
yeah, yeah. You mentioned earlier while you were chatting about listhesis,
Yep.
and can you tell us what type of X-rays are you ordering before, like PTs in the state of Maine cannot order diagnostic imaging yet. Some states can, but we cannot. But we oftentimes can give recommendations to providers before they go see you. And I know what the answer to this is, but could you explain to our audience what types of X-rays are helpful for you before they get to you?
You bet. Well, so, and there's a whole slew of X-rays that have been developed over the years, that can be useful for a variety of different things. But particularly when we're talking about and mostly degenerative things, and that's, I think, the vast majority of the patients that we're dealing with here. Um, then the main ones that I would focus on are a simple AP view looking straight on, and then a series of lateral images, what we call dynamic X-rays, or sometimes people call them flexion extension X-rays, where you ask the patient to lean their head forward and lean their head and neck back, and then one in what's called the neutral position. And really, the reason that I like those is because they complement, they're a supplement to the information that we get from an MRI. And the reality of practice in Maine in 2024, 2025 now is pretty soon, is that everybody's got an MRI. In the old days, that wasn't always the case. And so there were these what are called oblique views that a lot of times people would get. And those can be useful if, we were out in the woods or stuck in Antarctica and we had nothing else, then, that might help us diagnose things. But fortunately, these days, getting an MRI is not that big a deal. And so in the age of MRI, I think a dynamic X-ray is really the most useful thing. And what does it tell us? So it tells us, not just about alignment and osteophytes and, that general spondylosis that everybody gets, but it tells us about the dynamic flexibility of each joint. And while there is really no consensus of how much motion is allowed at each of the joints, there's a bunch of research on that, but still no consensus. I think there is kind of this threshold where once you see enough translational listhesis, in other words, the bone sliding back and forth over the other bone, that starts to wander into the realm of a diagnosis we call instability. And if a patient has instability, then it means that, they might be at risk for injury or irritation to the nerves or even potentially to the spinal cord. And paired with the information we get from the MRI, that can really help us in identifying the source and the cause of their complaints. Unfortunately, things like neck pain are not always associated with imaging findings. And so even if we find somebody who's got neck pain, who's got instability, and who we can see on the MRI has some degree of stenosis, if their only symptom is neck pain, it's going to be really hard to recommend surgery to them, because I think the most optimistic estimate I would be able to give them is that I might have as much as a 50 to 60% chance of making their neck pain better. And it's a puzzle. Why? I wish I knew, I mean, it
Yep.
just would make so much sense that, you take the picture, you make the finding, the radiologist describes it eloquently in a long paragraph of all the things that are wrong. And we fix that thing, and you would think their neck pain would go away, but it just unfortunately does not.
Yeah,
So
the
we
neck is so dynamic. It's so many moving parts, and we find that when you have that, it becomes more difficult to identify. What is the source of pain? And like I tell all of my patients, I told somebody this morning who came in. You get imaging done. And you can have all kinds of terminology in this imaging, and people now have access to their portals, which I think is, in my opinion, wrong for certain things like this. They get all excited. They start Googling all this terminology. They start panicking. They walk in here like, I'm going to die. I read my MRI report. And I'm like, okay, listen, you have this MRI report. It needs to tell us this. And for those of you who are just listening to me, I've got one hand in the air. And then the other hand is, what do they look like clinically? And so if you have a good, real good clinical exam, and that matches up with a good, diagnostic evaluation, might be through imaging, might be x-rays, MRI, whatever it is, as long as they match up together, then you can definitely target that area of pain a little bit better. But if they're not on the same plane when you get them, it just doesn't match up. You have to kind of step back and say, okay, are there other generators or pain generators that could be causing this discomfort? And, anything from suboccipital neuralgia to chronic myofascial neck pain. I mean, we've seen people who have weak anterior cervical spine flexors, and they just are super weak, or it could be postural. They're sitting at a computer for 8 hours a day. There are a lot of reasons why people have neck pain. It's not always because of an instability or foraminal stenosis or something like that. So I think that looking at the big picture is very important before jumping to the conclusion that, surgery is going to fix this.
Yeah, I totally agree. And a lot of times people will come to us and they'll say, well, my neck pain is really getting very severe. So I'm ready to, to have my surgery. And it's just a little bit of a disconnect. And, what surgery can treat, and in particular the ACDF can treat, is very effectively, it can take the pressure off of areas where the nerves are being compressed, or, in some cases, the spinal cord itself. And, but that doesn't necessarily correlate to pain. It doesn't necessarily correlate to neck pain. And I can't tell them that the neck pain is somehow instructive to me about what's going on. It just tells me that, unfortunately, they've got terrible neck pain.
Right.
But yeah, but the interesting thing too is, and we've talked before, is that, when you start dealing with issues of spinal cord compression, neck pain is not typically one of the signs that we see in that
Exactly.
sort of thing. People come in and they're like, I got no neck pain at all. I just can't walk.
Yeah,
I fall
I
down.
see this all the time, like, massive nerve root compression problems. Those people don't have palpable discomfort, or sometimes you can't even reproduce it. I've seen people with this one gal, the first one that I had ever seen when I first started the Marquis maneuver. She had zero neck pain, full cervical spine range of motion, and had a massive C5 nerve root compression. She had zero shoulder flexion. She couldn't use her deltoids. She had zero biceps. Couldn't supinate the forearm. It was so compressed, major nerve damage, but she had great cervical spine range of motion, and she fooled everybody. And then I tractioned her neck, and she was able to lift her arm over her head, and we identified that she had a nerve root compression. So, yeah, we see this a lot, and pain in that area can't be the only thing we go by. I totally agree with you on that.
Well, and I don't want to get too far afield, but getting back to the procedure, I just to kind of finish up, when we once we've successfully placed the interbody graft in whatever flavor we end up using, and then lock it in place with a plate, and there, again, there's a whole variety of different types of plates. Then it's really just a matter of cleaning up, washing up, and sometimes we put a little drain in, but most of the time we don't. And then we do a multi-layer closure of absorbable sutures, and these days typically closing everything with a glue, so it's a nice, neat, tidy thing. And then a couple hours in the recovery room, and they get to go on their way home. But it is a long, slow recovery, and I think a recovery from two physiologic perspectives. One is the perspective of the bone, and to get really good solid fusion, you really need to give it a good 3 months of not placing tremendous strain on that area. And then the other part of it is that we have to look at the nerve recovery, and while the vast majority of people, as you already pointed out, well over 90% wake up without the arm pain that they had, or without that sensory change that they had. Unfortunately, when we look at nerve recovery, and especially things like weakness, that's going to be months and months, and it may even drag out for a couple of years. And as you and I well know, there's the possibility that some of that injury is permanent, and so they may not fully recover it.
Right.
But I do think that fortunately, the vast majority of people do very well with this, and nerves, a lot like people, they are easy to irritate, but they're pretty resilient. And so you give them enough time, and they actually will rally and generally recover pretty well.
You have a common post-operative medication regime that you like to use with folks? I mean, I know it can vary with everybody, and people have a different tolerance to pain. But is there kind of a standard routine of medication you like to use
Yeah, so
after?
and these days it's different, right? It's evolved from,
Yeah.
when I first started, it was, we'd give them 60 of the oxycodones, and, also give them a bunch of muscle relaxant and maybe even a benzodiazepine. And I mean, it was crazy. But that was kind of the standard. That was what my senior partners were doing. So I figured, well, I guess I better do it too. But no, these days it's a very short course of kind of a low to moderate dose narcotic, and that's really their rescue medicine. Typically, it's an oxycodone. You can pair that with Tylenol. We do recommend Tylenol pretty much straight up for anybody who can tolerate it. Unfortunately, we don't really encourage the non-steroidal anti-inflammatory medications, things like ibuprofen or Aleve, because those actually can impair bony fusion a little bit. Now, in cases where you've got a patient who may have a really severe, like rheumatologic arthritis or psoriatic arthritis, where they're, literally immobilized by the pain in all of the other joints in their body, then that's a decision we have to kind of weigh, and we have to do the risk benefit analysis. But in that scenario, we might prefer them to take something like Celebrex that doesn't seem to have as much impact on that initial bony fusion inflammatory response. And that's the issue, is that when we look at how bony fusion goes, the first little bit of it is inflammatory response. And so if you start ladling these patients with lots and lots of non-steroidal anti-inflammatories, then unfortunately we'll see a lower fusion rate. And the
Yeah.
same goes true for steroids. And so we do, well, a lot of times give them a steroid pack. We call it the Medrol dose pack, and that's a standard, a type of a prepackaged thing the pharmacist can hand over the counter to them. But I should correct my speech. It's not actually an over the counter; it's a prescription. But they've got it prepackaged, so it's easy to deliver to the patient. But it's a useful tool to help reduce swelling. Helps with swelling in the throat. Helps reduce swelling in the nerves. But it is technically also working against us. It can lower the immune system, and it can also make it harder for them to fuse. And so there's a lot of study on it, and I think we've kind of come to a level where we think, okay, a low level of steroids useful. We try to avoid the non-steroidals as much as we can. We use a little bit of the narcotic pain medicine, really emphasize the Tylenol as our principal thing, along with non-pharmacologic pain things. So for example, heat or ice. Now, you're not going to want to put heat right on your incision. The patient will have tenderness here. They may even have bruising or swelling. So you're not going to put a bunch of heat packs on your front of the neck. But on the back of the neck, I got no problem with that. That's great. And that's actually where most of the patients are going to describe their discomfort anyway. And that's because, as you pointed out, we're separating this spaces, the bones that have kind of collapsed together. We separate them out, and all of the ligaments and muscles will feel that. And even though it's just a millimeter or two, it's like it's a whole new reality for them, and they kind of have the potential to go into spasm.
Yep.
And that's where using a muscle relaxant can be beneficial. muscle spasm is typically described by patients as a sharp, stabbing, grabbing, clutching kind of a sensation, really fairly focally located, and usually in the back of the neck. Sometimes it can migrate even up all the way over the back, and that's, if you get this kind of cascading muscle spasms. But yeah, into the trapezius, that's an area that we see a lot as well. And the trouble with all these medicines, especially the sedating ones, and the hypnotic ones, is that they have this way of kind of keeping the pain fibers, the C fibers, really hyper excitable. And so, patients that have persistent radicular symptoms or a postoperative neuritic dysesthesia, and that's where they get this kind of weird, unpleasant sensation. If you've ever, had a limb like a hand or a foot fall asleep and then it starts to kind of wake up again, there's this period of time where it's actually really pretty uncomfortable and you're like, oh, I wish that nerve would start to wake up. That's kind of a similar sort of thing that they can go through. And so taking a bunch of narcotic or taking a bunch of muscle relaxant to try to address that actually can make that symptom persist for longer. So everything in medicine is about risk and benefit, and so we just try to balance it. And my own personal prejudice is I typically try to minimize the amount of medication people are taking because I think unfortunately the risks are oftentimes understated, and
Yeah.
I don't really see a pill as the solution. I think I have to rely on my faith in the body's ability to heal, and also on people's ability to overcome it, their strength and will to do it, and then also, like I said, non-pharmacologic things, gentle stretching, a little bit of ice, a little bit of heat, maybe some icy hot, that sort of thing. And that typically works pretty well. This is
Absolutely.
not the most painful procedure ever. In fact, if you were to line up all the surgeries from least painful to most painful, this thing would fall very close to the least painful because for the vast majority of patients, it is not that bad.
Yep.
So, and that's not to discount the experiences of patients who may be listening who had the surgery and said, oh, it was the most painful thing I've ever been through. We're talking about populations here. I'm not talking about an individual experience. There are always, the opportunity for outliers to unfortunately experience a variety of different things.
Yes.
So,
Yes. Now, a quick question. I know that we've been kind of running quite a time on here, but and you're doing a great job, and I appreciate that. Any special considerations for smokers? Like if somebody comes in, they're a smoker. I know we kind of touched on it a while ago. I, as a physical therapist, typically am a little more conservative with these people afterwards, after they've had the ACDF. I just and I don't know, maybe I shouldn't be, but my thought is that they're just not going to heal and consolidate as well as those who are non-smokers. Do you ever kind of hold off on doing surgery if somebody's a smoker, or what are your thoughts on that? Do you have them stop for a while before surgery if they can tolerate it?
yeah. So the best advice we have always is to quit smoking, and I think if you step back and you kind of ask, okay, why are you still smoking? In other words, everybody probably tried cigarettes at one point or another, but for some people it really stuck, and they're still doing it, and it's probably treating something, and so that's I think an important concept to make sure that you recognize. And I do agree with you. You're absolutely right. So when we look at the risks of smoking and then going through any surgery, but in particular ACDF, all of the risks are significantly elevated. Everything from minor things to major things. So death, stroke, heart attack, all those terrible things. That's elevated for 2 to 10 times for people who smoke. And which isn't to say that it's likely. It's actually still very rare, but it's much higher. Things like wound healing happen slower, so wound infection is much more likely. And so, yeah, I do think you're right. And the biggest issue we deal with in the realm of smoking and doing anterior cervical discectomy and fusion is that we see a much higher rate of what's called pseudoarthrosis. And pseudoarthrosis is basically a failed fusion. And when a fusion fails, sometimes it actually can fail to create a solid bony union, but it creates a fairly rigid fibrous union, and that's good enough, and the patients actually continue to do well. But the potential, the risk is that if the fusion fails and they don't form any kind of a fibrous union, then there's still preserved motion. The joint continues to behave like a joint. Things can happen like the bone, which it's a titanium alloy. It's a very rigid metal. It can actually break So the screws can break, the plate can break, the screws can back out, the bone can break. And because it's behaving like a joint, these osteophytes and stuff can start to regrow. And so you can see recurrent stenosis and potentially recurrent symptoms. So pseudoarthrosis is a real problem, and we really struggle against it and work hard to try to make that as minimal as possible. There have been times where people are in such rough shape, and in particular with regard to the level of tobacco use that they have, that we've really said, look, yeah, we could do surgery, but the risks of doing it are probably as high or higher than the risk of not doing it. So quit smoking, get your health in order, and then you're going to do better. And if you still need surgery at that point, then we can reevaluate. But a lot of people have a hard time quitting. And so the data for anterior cervical discectomy fusion is that we still have a reasonable chance of pretty good outcome, even if they persist in smoking at what we will call a moderate level. In other words, they're, under a pack a day kind of a thing. There may be half a pack a day or less. So, and quantity counts, the less you do it, the better. And so if that's their scenario and they really have tried all their, their best effort, as it were, to quit, or they've got a syndrome that's, progressive neurologic deficit, we're really worried about them losing permanent strength in the arm or the shoulder, whatever, then we will proceed. And like I said before, we'll make a separate incision, typically down on the hip, and then harvest bone from there to place into the neck. And with that, we can still get reasonable success rates. It may not be 98%, but it's probably well above 90%. And it's a reasonable trade-off. And again, we're trying to, make choices that are, both safe and effective to try to help them, the patient, get preserve their neurologic function and get to a better place. So that's typically the issue. And yeah, the bony fusion and smoking are just, they don't go together. It's oil and water.
Yeah.
So
Yeah. Wow. So that's a lot of great content, a lot of great answers. And thank you so much for everything you've done for us today, Dr. Arredondo, in regards to educating us about ACDF. Is there anything that you think most of our listeners are PTs, OTs, people in the medical profession? Is there anything you want to tell these folks about, regarding treatment of these patients after the procedure?
yeah,
From our perspective, when we go to treat patients. Now, I'll talk about the treatment, from acute to subacute to, later on down the road. And we'll be talking about a lot of different concepts on how we manage these types of things and how to do it safely. But is there anything that you would say from a surgeon's perspective before that patient goes to see a therapist? Hit us.
yeah. So I think that the only reminder would be, just to remember that the strategy and approach that you might have preoperatively is going to be different postoperatively. And the only thing that I would really kind of caution against is in the kind of the immediate postoperative time frame, and let's call it the first 3 months, the use of cervical traction. I really don't know that I would get excited about doing a lot of traction on somebody that just had a fusion. I think the potential for triggering a lot of neck pain is real, but I also think that that's actually kind of stress we don't want to put on the neck right after that kind of surgery. And so if you have a patient that has some persistent, radicular symptoms, then probably thinking about an alternate path, maybe a reevaluation, maybe some more imaging, but it may well be that it's that, it continues that irritated nerve continues kind of crackling and firing. And we see that every once in a while. Probably 7% of the patients are going to have some sort of persistent, episodic, usually type of radicular symptoms that can be pretty unpleasant. So that's the only caution I would say. And then just to, kind of keep in mind that, yeah, as you go to, restore range of motion and that sort of thing, which is important, and you want to strengthen the neck, you also, you want to tread lightly because the structure there it needs that time to really fully, as you said, consolidate, because I think that's the best way to get the best long-term outcome.
Yeah.
And that's in distinction from the disc arthroplasty patients, which we haven't even touched on. And those are the, artificial disc patients. I think you can treat them pretty differently and be a little bit more aggressive with them. Those use typically a little quicker recovery. But we see those so rarely these days that, I think the ACDF really is probably going to be the vast majority of what your listeners are going to be running into.
Yeah, that's what I see a majority of also post-operatively.
Oh,
Um, so
okay.
great. So I know I probably missed some questions for Dr. Arredondo that some of you, our listeners, may have. So do know that we now have a new fan mail link on the podcast station. So if you go into the show notes, and right at the top of those show notes, there's a little section where it says that you can send a message. So shoot me a text with whatever question you might have. I'll get in touch with Dr. Arredondo. We'll discuss the answer to that. I'll bring it up during the next show, and I'll start with that before we get into the management of the patient after ACDF. So again, for those of you who are watching the Ortho Eval Pal podcast, I really appreciate it. I'd love it if you could give us a rating or review on Apple Podcasts or Spotify. It really helps to increase the quality of our content. And if you want to take it to the next level, be sure to contact me. We could do some online one-on-one coaching. But before we depart, Dr. Arredondo, I want to thank you so much for being on the show today. I really appreciate your time, your expertise, and for taking my phone calls. I know sometimes it may be a bother, but we've had some really great conversations, and I've learned so much by just these conversations and talking to you about how to manage patients better.
Well, Paul, you're too kind, and it's always my pleasure. And likewise, I'm constantly amazed and impressed at how well you serve your patients, and they are very fortunate to have you. And I also want to throw out, don't forget to like and subscribe.
Well, thank you so much. So I hope you all enjoyed the show. I hope you have a great day. Be kind to each other and take care.